This is yet another edition of the League of the Genuine Conversations with your host, Fred Muwema, every evening, every morning, every afternoon, depending on which part of the world you're watching this from. We're happy for those who are joining us for the first time. This show is dedicated to addressing the issue of counterfeits. You can follow us on our Facebook page and all other social media handles. You can like, you can share. We're happy that the support for the program is growing because I think the message is getting out there. Everybody is concerned. Everybody wants to be safe. So we should avoid counterfeits. This is a show that promotes consumption, use, and sale of genuine products. So as usual, we have several guests we've had in the past. This time we also have another special guest who has been kind enough to come to the studios and share with us their experience, knowledge, information about counterfeits. All this is intended to make your life better. So join me in welcoming Dr. Clarke Busuulwa, who many of you who live in Uganda could be knowing. Doctor, you're welcome.
Thank you.
I didn't know you are called Busuulwa. That is purely, I don't know whether it's an Irish name as well.
No, definitely not.
So how did you get the name?
So I came here about 30 years ago, and I came with a church mission. So I was under the Church of Uganda, the Anglican Church. My boss was the bishop, Malaria at that time.
Malaria, yes.
Kauma. And he came on we were very, very deep in Luwero, deep in the bush, you would say.
In Luwero district.
In Luwero district. And that's not very long after the war, the last civil war. And he came to check that we were here, and he found this little Irish family there, and he said, since you're right in the middle of Uganda, you need to be adopted as a Uganda. So I became Busuulwa, became Nachito.
Kobe clan.
So I'm Kobe clan, and of course she's a different clan, Spotted Monkey clan.
Monkey clan, okay.
Yeah.
Dr. Busuulwa, Clarke, you are welcome. We would like to join our brothers and sisters in the Muslim fraternity who have just ended the fasting. Happy Eid. And we hope that the year will be a year of blessing and that the Almighty will give you all your wishes. Talking about fasting, I'm always intrigued. The Muslims fast for a certain period of time. I know it's a religious ritual, but from a medical standpoint, are there benefits in fasting?
Yes, definitely. Fasting in moderation is something that can help you. It helps to detoxify, and people sometimes do short fasts, so they maybe fast 1 or 2 days a week. Sometimes they partially fast. There's the psychological aspect, which is discipline, but then there's a health aspect as well, which is basically detoxification. Although it has the caveat if somebody's diabetic or has some other condition, they shouldn't fast.
You know, this show is dedicated to exposing counterfeits. Unfortunately, even in fasting, I have seen some people actually who pretend that they are fasting, but they are actually not fasting. Isn't that really just to show how deep this faking thing has gone?
Well, that's just character. Okay, but there are exceptions in terms of the Muslim fast. In terms of Ramadan, there's exceptions as well for traveling or for health conditions. Yeah.
What would make Dr. Clarke, an Irishman, to come deep down in Africa, and moreover, you didn't start from Kampala, you started maybe 200 kilometers away. There isn't all the amenities that you are used to back home. What is it that keeps you here? What is that passion, that drive? What makes you, what's the motivation?
So the first thing, that really where Uganda caught my attention when I was a doctor in Ireland was HIV. So back in the mid-80s, HIV was really ravaging Uganda, but Uganda was one of the first African countries that was sort of went public about HIV.
About the problem, yes.
Yeah, and so I was sitting there in my doctor's office, measuring blood pressures and treating fairly mundane conditions, and I thought, my goodness, there's a place that really needs medical help, and that's really, that was my motivation in coming, and I found myself in the Luweero Triangle, and really in the midst of
kind of the epicenter of the.
Yeah, I don't say it was the epicenter, but Uganda was so bad then. I mean, the positivity rates, somebody told me in the army at that time, were about 75%. And the positivity rates in the general population were about 28%. So it was devastating. And I mean, I lost so many friends to HIV, and of course there was no cure for it then. So that was the thing that drew me in. And then we built a hospital called Chiwoko Hospital, which is...
Chiwoko.
Yeah, K-I-W.
In Luweero.
Yes, K-I-W-O-K-O. Chiwoko.
It is still there.
Chiwoko. Yeah, functions very well. And I'm still involved in that hospital at board level.
Was it a church hospital?
Church hospital, yeah. And then subsequently, after about 6 years, I decided to come back. I'd done my stint, and then I did a master's in public health then in London. And then I came back to Uganda, but just on a private basis as a doctor, and started a clinic. And my motivation then was basically that you can bring development through aid, but you're always begging, you're always looking for money. But Uganda was developing itself at that stage, and I thought, if I can do something that is actually people pay for, then I can develop a service and it can be sustainable without donors. And that's really what that was the seeds of what became International Hospital.
So then from Luweero you move into Kampala.
Kampala, yeah. Mm-hmm.
And what was your first engagement in Kampala?
I had a small clinic in what is now called Watoto Church, and there in that complex, the old Norman Cinema.
Yes,
I had a clinic there. I'm at the first international medical center. I think there are now about 20 international medical centers throughout Uganda.
So you opened the first one,
yes.
And then you scaled up to...
Scaled up slowly. People want to go from here to here, without going here to here to here.
You need to talk about that because these days, somebody finishes school.
Yeah.
Within 1 year or 2 years, they must have their dream car, their dream house. It is something that is really eating away at the soul of the nation and maybe even affecting labor productivity. But it took you probably 10, 15 years. How many years?
15, 20 years, yeah.
15, 20 years.
To build up the whole thing, yeah.
To come to the IHK, the International Hospital of Kampala.
It came before that, maybe 10 years or something, but, to get to the level it's at today, it's been going for 20 years.
About 20 years. So your message to people out there, the young people, the guys who finish school, what is that trick?
It's like a journey. Each journey is, one step at a time. And if you can grow incrementally, then you learn as well. Or you're building a house, you build one brick at a time. So for me, my philosophy is that you take each experience that you've got, and then you learn from that, and then you acquire new knowledge, and you keep building. You build yourself, you build your organization. And you don't need to be the idea that I must have it now, and then here we have this sort of, Uganda's divided into, most people are very poor, but then there are those who are rich lawyers like you, Fred. Okay, but then you find that somebody wants to have all the, they have the big wedding, they need to have, spending money on that sort of consumerism and that isn't really building anything, that is flashy, is about image, doesn't build anything. If someone builds their business knowledge, builds their character.
But don't you think that for the young people there is a dilemma there, because they're in a world where the internet provides all sorts of information. You can have, if you want to know how to be rich, how to be successful, somebody can talk to you in 3 minutes and give you the tips. on how to be successful, how to make money, how to be happy. Everything appears to have a technological backup. Don't you think that is complicating the real life journey for people?
I think there isn't such a thing as I needn't say there aren't people who have become rich very fast, but these are people like Mark Zuckerberg or a long time ago Bill Gates. You know, these people who hit on something that could scale worldwide very quickly.
But even that took time.
Yeah, of course that took time as well. But most businesses have to be built, you know, step by step. Now that the steps might take you 1 year, 2 years, 5 years, 10 years. Okay, but if you're going to have quality and substance, you're going to have you know, build it and learn it. One of the things you were asking me earlier about millennials. Millennials are very they're great. You know, I love young people, but so much of their knowledge now is acquired by scrolling through the phone. Okay, and they're not, millennials are not reading. This is Ugandan ones. They're not reading, and even worldwide, there's less reading going on. And I was asking one of my other assistants. She was reading a book, and I said, "Oh, you bought that book?" And she said, "No, I'm reading it on the phone." And I'm like, "But you know, it's not even a tablet." And she reads 2 pages a day, you know, so that takes her a long time to get through the book. And that's one of the things, you know, people need to still have those skills of concentration, of focus, of actually building up themselves in terms of their knowledge and their understanding. Abraham Lincoln, I was reading a book about the American presidents, and Abraham Lincoln was dirt poor. Had nothing, and that guy was self-educated. His father thought schooling was a waste of time, and he had such a thirst for knowledge. He taught himself law. First of all, he taught himself English, and then there was not very many books, but he would get any book and read it, and then he taught himself law, and then he taught himself philosophy, and he taught himself understanding of life, and the anti-slavery thing, you know, that he began to understand these things. And that's what I'd like to see in all of us, you know, and that's what I'm still in my journey of still trying to understand life, expand my mind, be a better businessman, be a better person, etc., etc.
But the millennials might hit back and say, "You guys, you don't understand us. If anything, it's not us who are fake. It's you, the parents, who have been poor at your job, and therefore you are the very reason why we are where we are." So who is to blame here? The millennials, the fake ones, or the parenting?
No, it's not. I mean, it's neither. It's neither. Let me say, millennials have certain skills that I don't have. Comes easier to them. You know, the whole social media, internet, and all that kind of thing. I mean, I can type on a computer, but I can't do much else. That's why I have a millennial who's my assistant. But what we've got this issue. It happens in America. It happens in Western countries, but it's also in Uganda, where you've got so many young people who are brought up by one parent. So the parents, this thing of role models, of mentors, is too scarce in Uganda, and so therefore often the role models are the wrong role models. If you're in the village, who's the role model? The role model is the guy who owns the taxi, or the guys who drive the botus. Okay, that's as high as the aspirations go. The role model is not really the school teacher, so there's faults on both sides in that sense.
We're a very young country. So if we're talking about the subject of counterfeits, then the biggest group of people that are affected are the young people, the millennials. Can you walk us through your experience with counterfeit medicines from the time in the 80s when you were dealing with HIV treatments to the time of setting up, I think at one time it was the biggest hospital, private hospital in Kampala. What's your experience with counterfeit medicines, and how do they affect the different age groups, the older people, the middle age, and the young ones?
Well, first of all, as a generalization, young people don't get sick as much as the
Older ones.
middle-aged. As you go through life, your body tends to break down more. So I don't see young people as particularly villains in this. But what we have is this a society that is a poor society. Even those who are in jobs and so on, they don't have excess money, and so people are always looking for the best value for money, sometimes the cheapest thing. And I think that, we have a lot of informal drug shops and dead baleros and this kind of thing. If you go along any street, you'll find all these things. And to me, someone goes in there and they get a few pills, a handful of coloured pills, and they may not be even talking to, they're probably not talking to a medical doctor. They
There's
might be
no
talking
pharmacist.
to a nurse. Probably not a pharmacist, because pharmacists have these things where they can, license to businesses and do another business. And so these little places I'm talking about, around the village, the little places in Namawongo, in the slums and stuff like that, people don't really know what they're getting, and so they're given all kinds of medicines. Now, those medicines themselves are not necessarily fake, but it's the treatment that's fake. So somebody goes,
What do you mean?
Well, it used to be, and still to some extent is, but it's less now than it used to be. The word for malaria is nasuja, but the word for fever is nasuja. So therefore, in the definition, nasuja, fever, is malaria. They're all the same thing, right? So when you go to a doctor as a Ugandan, and this is less so now, people are more informed now, thankfully, you're telling the doctor, I have nasuja, I have malaria. So you're telling them, give me the treatment for malaria. So people just, you want to save somebody, well, you don't even bother with the doctor and the cycle. You just go and say, give me some malaria treatment, Or now it's infections. People tell you, oh, you've got an infection, so you give me some antibiotics. The drugs might be okay, but, there's, like, for example, typhoid. The diagnosis now of typhoid, how many people do you know who've had typhoid? But if you were to scientifically test for a rising teeter and demonstrate that person had typhoid, very few people have typhoid. Not none, but very few, okay? The reason why there's been a dip in the whole malaria thing is because they started promoting rapid tests. So it's easy to say, it's like a pregnancy test. You're negative or you're positive, okay? Whereas before it was always scanty malaria, incubating malaria, and so on and so forth. So I wouldn't say that those medicines are necessarily fake, although some of them are, and some of them are out of
But
date.
have you had an encounter? Have you had an encounter with the procurement
Yes.
of fake medical supplies?
So you need to be, from me, there are checks.
Or how do you ensure that?
Okay, there are checks and balances in place. Okay, so we have a national drug authority. That drug authority is supposed to control every drug that comes into this country. Now, when a drug representative, when a wholesaler here wants to bring in certain drugs, the manufacturer or the wholesaler has to pay about $5,000 just to get to National Drug Authority to bring in one tablet, one particular tablet, because NDA will actually send people to the factory where those drugs come from. They will check on all the registrations and so on and so forth. So as a generalization, this system works, okay, as a generalization. But certainly you can get instances where drugs are smuggled in and where you have fake stuff or out-of-date stuff. Now, what I've done is to make sure I'm buying from the big, well-known manufacturers. So a lot of our drugs here come from India, because India makes the generics, which are quite fine, but you need, within that, I wouldn't buy from some small Indian manufacturer I've never heard of, because what is that? But if it's Cipla, it's okay. If it's many of these, the big names that I can't even remember now, but if they're a big name and they've been certified by NDA and they're imported often by joint medical stores or Abacus or some of these big distributors, then they're quite careful. But when you go down to Chikubu, down to those funny drug shops, and you buy something you've never heard of before, yes, of course you're going to look yourself.
But unfortunately, doctor, most Ugandans or Africans, for that matter, cannot afford your kind of service because you will procure from the best source, so meaning you pay a premium price. You will ensure that the channel is followed, distribution channel. You will ensure that your patient gets the best drug possible. But the majority of people can't afford.
Well, I think we know that in terms of, you're a lawyer, and you know all about patent laws. And we know that there has been a concession to the South okay, to countries like Uganda who can't afford to buy every drug from Pfizer or from Roche or from these
Novartis.
these big initiative manufacturers who, and so what happens is, so you have the brand. So the brand might be, simple example, Panadol. That's a brand, okay, but the generic is paracetamol. So you don't have to buy Panadol to get paracetamol. And if you buy from a generic drug from a known manufacturer in India or a known manufacturer here
locally,
in Uganda,
like Cipla.
yeah, yes, like Cipla, or there's a number of these Uganda pharmaceuticals and so on. Then those drugs, there's no problem. When I buy something like ibuprofen, I don't have to go and buy the Brufen. Okay, I can buy the ibuprofen, which is made in Uganda.
But
And
some
it
people
works
think
just as well.
that the generics are counterfeit.
This is the point. I want to really be clear on this. A generic drug is not a counterfeit. An Indian drug is not a counterfeit, okay? But because India is such a big supplier of drugs, counterfeits can originate in India. And the way that we guard against that is we follow the procedure, we make sure the drug is approved by National Drug Authority, it's brought in by one of the big people, it's from a manufacturer that you know is a big manufacturer and has all those checks and balances, okay? And then you're okay as a generic, okay? But don't buy something that from some manufacturer nobody's ever heard of.
But sometimes the pharmacists will ask, do you want prednisolone from Germany?
Yeah.
We have Cyprus, Pakistan, and Kenya, and Uganda. So it's wrong that they should be asking this because it appears there's a preference issue there.
No, that's fine. When you buy the German drug list, you know, the same, you buy the, I can't think of the name of the drug, but the antibiotic or whatever it is from Germany, compared to the generic produced by Cipla in India, there's probably a differential price of about 10. Okay, so one drug can cost you $10 and the other drug costs you $1.
But are the active ingredients?
The active ingredients are the same, okay? But you might get somebody who says, I have the money. I don't mind spending this money. I want the German brand. Fine, okay. Now where the problem comes in now is with medical insurance. Because medical insurance in Uganda, even the private medical insurance, is very cheap. Medical insurance in Uganda runs
What's the range?
It's about $200 a year. I'm sorry, I'm quoting in dollars here but let's say it's 600,000, 700,000, okay, for medical insurance here. To compare that to South Africa, so that's say $200 here. South Africa is going to be in medical insurance. It'll be $200 a month. You know, never mind $200 a year. So in order to give you the most affordable and best value medical insurance, of course these insurance companies are not going to buy the German drug, they're going to buy the Cipla Indian brand, or Indian generic. And that's perfectly fine. So the problem comes in when people say, Indian counterfeit. No, that's not true. And I want the German one, fine, if you're paying for it yourself, do that. But we, as a generalization, can't afford to pay those prices.
So do you think that medical insurance per se helps to lessen the burden of counterfeits, or it actually promotes counterfeits? Because some people will be on the medical insurance.
It can't promote counterfeits, because if I have a medical insurance company and then I'm pushing people to buy generics and then those drugs don't work, you'll soon get a lot of complaint and a lot of stuff coming back to me. So you must ensure that you're following procedure and you're buying the right generics.
Why I say that is because some people will say that once you have the insurance card, that the healthcare provider will try to get as cheap as possible to make a return on whatever you paid.
Yes.
So therefore they are likely to go for the counterfeits.
Yes. Well, they can't go for the counterfeits because there's a lot of regulation around that whole thing, okay? But it's more about being sustainable in terms of value for money than as cheap as possible. And I know that from having run a medical insurance company, for many years. But now you've got names like Prudential here, you've got these international names, and there's no one who wants to overpay for drugs. Drugs are a big part of a bill. But if you're providing insurance for $200 as opposed to $2,000, then you've got some limits to be realistic. And I'd like to take that further. The National Health Insurance Bill has been approved by Parliament, and if NHIS comes into being, they're definitely going to have to provide generics. They're not going to be, when you'll find that the contribution per person in this will be very, very low, and how are you going to provide the best value? So you need bang for your buck, And you need, by the way, in terms of counterfeits and so on, what you need is more prevention. You need to stop people going to the doctor in the first place because you have a healthier population.
And yet, despite what you're saying, the insurance bill, and we have a lot of measures and controls, the reports we receive from the World Health Organization and other, is that a lot of life-saving drugs in Africa, HIV, malaria, tuberculosis, cancer, a lot of them affect. Where do you think the problem is? Why is it that we are so prone to consuming fake, including medicines? Do we not love each other, ourselves enough? Is it an inherent problem?
Well, people would say in Africa it's poverty, because some of these fake drugs are really in the periphery. You know, they're in the small village pharmacy, as I said. They're either out of date, you know, they've got some issues, but people want something for nothing or something very, very cheap, and so they just take these drugs. I doubt that you take any fake drugs. I doubt that I take or these people take any fake drugs. But when you're a non-educated villager and you have very little money, you know, and you go with your 5,000 shillings and somebody gives you a drug, so it's lack of education. It's yes, counterfeit drugs that
are pushed more by poverty, but Doctor, Uganda is trying to get up to the middle income status. Middle income status works out at maybe 3.5 million shillings or 4 million shillings, about $1,000 or 800 a year. Now, even if somebody was at middle income status, $1,000 a year, if they had a medical condition like cancer, we have learned that a treatment for cancer can go up to $10,000, $50,000. Still, those persons would not be poor, but they will still not be able to afford. And yet the cancer drugs are also being faked. So I think I think the issue of counterfeits is more than poverty or affordability. There must be other factors that could be pushing things like differentiation. You cannot differentiate the genuine from the fake. The guy who would be buying the fake cancer drug may like to do some saving on the cost, but he or she is more driven probably by the factor that they cannot differentiate. To what extent do you think differentiation?
But this comes down to education, because education and early detection. Because with cancer, once you're at a certain level in the cancer and you're needing chemotherapy and you're needing these kind of things, your chances of survival have actually gone down. But if more cancers could be picked up earlier, and that comes with education, then and there's prompt action, then they can be treated. And you know, one of the things that I would have liked to have seen with the Cancer Institute. Cancer Institute in Uganda is a very fine historical legacy in terms of, you mentioned Burkitt's lymphoma. Some of these discoveries of the etiology or the causes of certain cancers came from Uganda. And so it is a fine history. But it has been overwhelmed by patients. And my analysis of the Cancer Institute, it's still trying to do everything perfectly. So a person comes with their cancer, they say, go and get a biopsy, go and do this and that. And a lot of the procedures that happen now, and because of the crowds in the Cancer Institute, result in delays in treatment. And so the disease continues to progress. If somebody has breast cancer, and you're a young girl, breast cancer occurs earlier, at least a decade earlier here. Ugandan women can get breast cancer in their 20s. It's far more common in the 30s and 40s than in Caucasians. But if somebody feels a lump in their breast, and then they go quickly and they see the doctor, they get the investigations, and they get the lump treated, then their chances of survival are good. But if they go with a lump, then they're delayed for a biopsy, and then they're delayed, they have to go back to the village, blah, 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 all this kind of stuff. Then the delays themselves, by the time it comes to the treatment, they've got a more advanced stage, which needs chemotherapy, which needs radiotherapy, and which needs...
And chances of survival.
And the chances of survival are less. I would love to see that the treatment of cancer in this country had a budget which allowed for that and the drugs were paid for. There was maybe a trust fund or a revolving fund or something that provided them for the radiotherapy and so on. I mean, the Cancer Institute does a good job in terms of it providing,
but limited resources.
But limited resources, and it's like trying to be perfect in an imperfect world. How does that work?
Doctor, you mentioned something about education.
Yeah.
Education of, you didn't mention who, education of the patients or education of the doctors and so on. And what we are doing here is basically part of that scheme of education.
Yeah.
Now, so wouldn't you like to take some blame as a doctor that you guys have not educated us enough to tell us the warning signs, to tell us when to go for the checkups? You are so selfish, you keep the information to yourself. Is that a fair assessment of the doctors?
Let's broaden it, not just to cancer, but to generally health education. And I think that, yes, there's a failure. And you see a failure here in this COVID. Because you see a failure in now where people don't even think COVID is real, okay? And people have a lot of vaccine hesitancy. We brought in 800,000 vaccines. We've used about, so far, not even half.
But they're about to expire.
After 2 months. I don't think they'll expire. Okay, well, but here's the issue. Because there's so many rumors, the social media is rife with amplifying rumors of, oh, it has side effects, oh, it will make you infertile, oh, you'll die of a clot, oh, you shouldn't take that thing. And even doctors themselves are, I interviewed a doctor who 2 months for a job, 2 months after being available to health workers, the guy hasn't been vaccinated.
A doctor here?
A doctor here, a young doctor here. And said, oh no, they haven't come to us. I said, but it's your responsibility to go to the district health officer and get the vaccine. I mean, I didn't give him the job because I can't have someone who doesn't have any belief in science and is more put off by these rumors and stuff. When you do the relative risk, okay, of even, forget about all these rumors that it's going to put nanorobots in your body and you're going to all that. So forget about that rubbish, okay. The side effects are, the highest is 4.5 per million people, okay? Now the death rate from COVID is about, let's call it 0.3% or something overall. It's not high, but when you compare 3 per 1,000 with
the mortality.
Yes, with 4.5, or let's call it 3, just to round it off, per million, that means it's, what is it, 1,000 times higher risk of dying from COVID than having the risk of a side effect, not even death, because nobody's died from the vaccine, from thromboembolic effects. Doesn't make any sense. My workers on the farm, I had offered we would bring somebody to vaccinate the workers, and only 2 people wanted to take it up. So I was on the farm, and I got these guys, and I just said, hey, come. I talked to them about vaccines, and I gave them that risk profile. And I said, I've been vaccinated. You guys all need to, if you got the opportunity, get vaccinated. 40 of them then got vaccinated. Because I, as a health professional... Because
of your influence.
Exactly. And that's why I think we're failing as far as...
But Ian, I know you've said there's a lot of rubbish out there, social media, some of the, what you might call the rubbish, which actually affects people of our race. A lot of Africans out there believe that you guys are up to something, you're making this vaccine to exterminate the black man, I don't know, you want to take their everything. How can you give assurance to the African out there, being a white person, though you are African now, you stay here, how can you give assurance to those doubting Thomases out there who think that this is targeting black people to exterminate them? Is there any truth in that?
Absolute rubbish. Absolute rubbish. I don't think I can, if somebody decides to believe in conspiracy theory and in, all this fake stuff, which is absolutely amplified by the social media, I don't think I can, it's up to them to, I'll offer them scientific evidence as I did to my workers. Your risk from not getting it is much, much higher, order of times higher than your risk from getting the vaccine. But what I think happens is this. I saw a program on CNN this morning, and it was talking about how on social media and mummy groups, these groups of mother and babies, they form themselves into groups and stuff like that. There's an awful lot of targeting of them saying, oh, you know, you can become infertile, your periods will be disrupted, all this stuff to these pregnant girls or girls who want to who have just had a baby. And of course they think, oh, will this affect my baby? You know, and they're genuine concerns. Now those are white people. When that then reaches to an African population in the States or in Africa, it somehow gets magnified. It's like, well, if those people are worried, we should be 10 times more worried. It causes fertility, you know, where someone says, I'm worried about, you know, to say I'm worried about fertility, and the doctor says, well, there's no worries, it doesn't cause infertility. But then somebody has heard I'm worried about it. Then when it comes here, they cause infertility, you know? That's the amplifying chamber.
But then wouldn't you put some blame on these social media giants like
Absolutely.
Facebook?
I think Mark Zuckerberg has a lot to answer for.
Why would they shut down the accounts of President Trump because he's promoting white supremacy or hatred and so on, and then leave on those guys who are busy spewing out a lot of information or misinformation about the vaccine?
Well, it's very simple. They're making money out of it.
They make a lot of money.
They're making money. It's the algorithms. Ask the millennials here. They know the algorithms put you in groups. The algorithms are there to classify you so that they can sell more stuff to you. You know, the amount of data that's being collected on all of this, you know, through big data and artificial intelligence is scary, scary stuff. But the result of it is that you get put, you know, if you're a person who expresses a certain view, you'll find yourself siloed into a group with other people expressing that view. So now it's an amplifying chamber. And in fact, so what the social media, the very best that algorithms have done, by trying to categorize us into this guy is a football fan and therefore I can sell to him, you know, that everybody's getting more and more siloed and extreme.
So you agree that the lack of money promotes counterfeits, and the urge for more money also promotes counterfeits.
Yeah.
That's basically it. Because if the guys will leave the fake news and the fake information out there because they're making the money, then that's a motivation, we can say.
Well, when you say counterfeit, I mean, it certainly produces fake news. And one of my big issues is, where is science today? There is less belief in science than there was when I grew up 50 years ago, you know, 60 years ago. If you look at the last 200 years, it has been the Enlightenment. That has got us to all the wonderful stuff we have today in terms of technology and the Industrial Revolution and so on and so forth, science-based. But now people think that they can, no. Let me tell you a story. As we said, I came to Uganda in the height of the AIDS epidemic 30 years ago. So first of all, actually, AIDS was a bit like COVID. The tests they were not sure about, but then they got good tests. And so when I tested people, and then the results came back, and I sat them down and I said, look, I'm sorry to say, you've got HIV, you're HIV positive. And many of those, in that time, interestingly, a lot of those people were dead within 3 years of me, you know, telling them the HIV. Now, usually they got tested because they had some symptoms, like herpes zoster, you know, the rash you get, that was very common. So while they had the symptoms, I would agree, yes, I have HIV. Now, fast forward maybe 6 months later, they've been discharged from hospital, but I'm in the village, so I know the people, I bump into them, some of them are hospital workers. And I say to them, and I find they've remarried. I say, but, you know, you're HIV. I explain to you the risks, you'll transmit it. They would say, yeah. So they would say, well, so you say. I'd be what? So in other words, they were saying to me, it's your opinion that I have HIV. But for me, I don't think I have. I mean, my rash went away. Now I've got married. I'm normal. So I could not get them to believe scientifically that this was an absolute fact. For them, it was an opinion. Now science has become an opinion. I can't believe that people have gone back in the Western world 30 years to where I was at in Luero, okay, when people didn't have any education and didn't understand science. Now that people are rejecting science in favor of gossip and social media. And
what you're saying is a very, very important thing. Actually, in the fight against counterfeits, the major issue we have is that people have their own opinions, they have a mindset, set in a certain way.
Yeah.
This is what we've done
Mhm.
for years and years. So you may not come and tell us that it will make us sick and so on. But I think still there is a small factor there in the science that makes people very skeptical, especially if you hear things like the US, for example, has a lot of leukemia, blood cancer, because of the use of so much electronics, and mobile telephony penetration is at the highest. So a lot of blood cancers are coming through there. You hear again, I don't know that it's fake or not, that the 5Gs, I don't know, the 6Gs are causing radiation and so on. Don't you think science also is to blame for this kind of mindset that we've got, and therefore is helping the counterfeit culture?
No, I don't think so. I mean, I think that in fact, when there's they've done many studies on all these things, but if you don't do a double-blind randomized trial on something, somebody asserts that there's radiation coming from the mobile phones and stuff. They've done trials on this, okay, and they haven't found linkages. You take the MMR, the measles vaccine, okay, man, you know, people said this caused autism. No scientific fact, none. But you can't. The problem is when those opinions, those rumors go around social media now. You know, it's like if I've read it somewhere on some website, it must be true.
But even the scientific issues,
Yes.
Doctor, have been subjected to legal scrutiny and inquiry. For example, the case of Johnson and Johnson.
Yeah.
We have read that in the US, Johnson and Johnson has caused cancer to the ladies, and it's not safe. The talcum powder for the ladies, that it has asbestos.
Yeah.
Now you have one. The guys who have sued Johnson are relying on a scientific opinion to support that view.
Yeah.
And then Johnson is also relying on a scientific opinion to say it's not true. So science is not.
No, science is still there, and they're both using science. Now, what you have
science
to
is
look,
confused also.
No, it's not confusing in the sense. What you've got to look at is the relative risk. Okay, you've got to look and say if talcum powder causes cancer, Johnson talcum powder. How many people? Because you can't say that. You know, where's your scientific proof for that? How many people was it? Okay, and what's the risk of not using it, or the risk of using something different, or whatever. Maybe talcum powder is not a good example, but COVID vaccine is, because we know many people, 35 million people in Britain have been vaccinated. Britain is now reducing the social distancing and wearing masks, and their rate of COVID cases has plummeted. Okay, as I said, your risk from dying of COVID might be 0.3% or 0.1%. You do the statistics, the risk of the vaccine scientifically is far lower. Okay, so I'm not saying that things don't have risks, but you have to look at those risks. Okay, now some drugs, aspirin in children, was withdrawn because it caused forget the syndrome in very rare cases. But they said, okay, because there's other alternatives. You don't need to use aspirin in children. You can use ibuprofen. Okay.
Monsanto, there was a story on Monsanto.
But
they also said it caused cancer, and the court in the US made a ruling and said that product should be banned.
Well, it's not banned in the US.
It's an anti-weed.
It's a weed killer, yeah. It's widely used in the US. However, some people brought a case against it. But if you look at the good, if used properly, by the way, over 30 years, the good that being able to control the weeds has done in terms of producing more food for people, because then the crops grow, the maize grows, as against banning that thing, okay, on a very, because it caused a very small amount of,
damage to a few people.
You have to weigh this up.
But still, being a scientist, I think you're doing an incredible job trying to defend scientists. But still, there is some science or scientists who use their skill for evil purposes. For example,
very much.
COVID is a creature of science. COVID does not occur naturally.
Yeah.
Is that true? It was created by
COVID is a
scientists.
zoonosis. COVID is a zoonosis. It's skipped, and that's where most of our.
It's not from the lab.
No.
COVID.
No. There's no evidence. There's no evidence. Okay.
So
some
do you
people
have evidence that it didn't come from the lab? COVID.
No. I don't have evidence either way, but the evidence, the balance of evidence is that it came from bats through pangolin into the food markets and can
But
that way.
Dr. Ian, we've had bats here. I'm sure you saw them in
And
Luweero.
we have Ebola.
How come we didn't have COVID in the 80s?
We have Ebola
Why did the
from
bats
bats. It's another zoonosis. HIV was probably a zoonosis. HIV was probably in simian monkeys. Okay, most of these viruses we're worried about, these epidemics, come from pigs. Pigs are big from bats. Bats is a very, very good host. Okay, and we'll have more of these SARS.
So are you saying that those labs we hear in those cities there cannot produce a virus?
They can produce a virus. Yeah. This is all genetic. One of the foremost fronts, okay, we have at the minute is big in terms of technology, big data, artificial intelligence, and bioscience. Okay, and that's genetic GM really. Okay, and you can use it like for GM. People have rejected GM. Okay, GM foods, not in America but in Europe. Where's the science behind the rejection? There's none. There's just stories. Okay, there's no science, but people are just afraid of it, and so they've rejected. That's okay. But that is a frontier. Okay, genetic modification. That whole the Pfizer vaccine is mRNA. It's using a little bit of RNA to fight against the actual virus itself. And these things are at the frontier of science, and science can go wrong. But generally speaking, there's enough checks and balances in 99.9% of the cases that this science is really benefiting us. This science is doing away with disease.
So are you telling the Africans, the people watching now, go get your jab,
go get your vaccine, man.
AstraZeneca, should we look for Pfizer, Moderna?
No, I mean, this idea that I wait for Moderna or Pfizer, to me, if you start it with Pfizer, finish, would you start AstraZeneca, take AstraZeneca. That's the one I've taken, and I think it's very good. I mean, it's cheap.
We need to close this, but I should still talk to Dr. Ian Busuulwa, the politician.
Oh, right.
Were you kicked out of office? He was the mayor of Makindye division. I think
I resigned. I resigned because I was frustrated. You know, there was no funding for that. Not for me, but to keep fixing the potholes, and because I was in the division of Kampala, so my responsibility was to fix the roads and fix the drainage and do public health and collect the garbage. Very, very mundane things. And I did. I mean, McKinney was in a lot better condition when I left it. But, staying on, I was just going to pick up a salary.
You resigned because there was no funding?
It was very, very frustrating.
I thought we have a structure. Money comes from the top down to the local government, and then you collect a lot of money from the licenses. Were you guys using the money for your allowances? The division collects money. It's not enough?
No. They depend a lot on the central government grants. So therefore, when Kampala doesn't vote for the big man there, there's no real pressure for him to make sure this comes through. So when they cut something, so they keep the security budget, or they keep the state house budget, or they keep some other budget, and Kampala has a budget and it's there, but it's late or it never arrives, and so they're just, so that it's frustrating. But government processes are another conversation.
But you resigned from being the mayor of Makindye division, and you still stay in Makindye division.
I do, yeah.
So you're in a resigned place, basically.
No, actually, I resigned as mayor because I stood for MP. Okay. And when I stood for MP, I then discovered at that level the polarization of politics. So that was the election, if you remember, where the ballots were all delayed in Kampala. Some polling stations got them at 3 o'clock in the afternoon. By the time those ballots arrived, everybody was voting the key. Everybody. The same way as this time, everybody voted MIP. And I was like, man, I stand on my record. I'm not.
So which party are you? Are you the Irish party, the NRM?
I'm the Clarke party.
You're no party.
Yeah. I'm just there for the issues. But that's unusual in Ugandan politics. That's one of the things now that people, you've got to be,
You have to either for us or
against us. Yeah.
But you are still influential enough to have made it to the National COVID Committee or something? Fundraising committee. Yeah. You guys got a lot of money. I don't know. Did you line your pockets or something?
Nobody got a shilling from that. We were all reckoned to. We didn't even get expenses or anything at all. And we raised 29 billion shillings. And we actually decided what to do with that money 6 months ago. But because of government processes,
I think it's in process now. From the 29 billion.
What did I get?
As
Ian Clarke, I got nothing. Of course, I got nothing.
But people have the impression you guys sat and...
I think within the next few months that they'll see 280 pickups arrive in Kampala, like this procession of cars you have now parked at the at Kolo. So people realised that money was spent, but the government processes are so entangled that even when the president approved, our budget was for pickups, which he wanted for the rural health centres. It was for 2 blood banks in Truro, that side, and it was for border posts for medical, for all these trucks coming across and stuff. And that was agreed, and I say 6 months ago, 6 to 9 months ago. And after that, it was like it had to go through Parliament, it had to go through this and that and the other. I understand now that it has been allocated, and we should be seeing these things happen.
So did you also resign from that task force?
No, you don't resign from
you're
that.
still there?
You're
just quiet.
You stop meeting kind of thing. So.
But it looks like you're a very optimistic person, despite the frustration that you've had. And probably that's why you've stayed this long, 30 years, and you're still counting. You're in Uganda. What's your attraction to Uganda?
I like Ugandans. I mean, in the sense that Ugandans and Irish are quite alike. We're both sociable. We're people-centered. We are interested in people, not just getting the job done. And sometimes that makes us inefficient. And Ugandans, I find, are very inclusive. They're, so I come from Ireland. The fact that they even elected me to be a politician there, and I find if you're open to Ugandans, they'll be open to you. If you can come here as a white person and just have your own microculture, and they'll not harm you, they'll not do anything, they'll just leave you there. But if you're open to them, then they're very good. And also, I'd like to say one thing about Ugandans. People like you, Fred, and I'm sure the people in this room, smart Ugandans, they don't actually even realize that they're smart internationally. And if they were to all use their talents in the right way, Uganda would be this incredible country. But unfortunately, with wrong role models and people wanting to get rich quick and the corruption and so on and so forth, we find ourselves in the position that we're in. But Ugandans as individuals, I think they're great. Yeah.
So Ian here
that's
says,
a generalization, of course. It's not Ugandans
not everybody is like that. But since you say the Irish are like the Ugandans or vice versa, so if I went to Ireland, I have a chance of being a mayor, maybe even president.
Why not? Yeah, I know.
You'd vote for me.
Sure. Well, I'll have to assess if you're any good or not, but I wouldn't be on the basis of your skin color. But no, I know there's some Ugandans in Ireland doing very well. It's a small place, Ireland, but it is very sociable, and it's Uganda's like 40 million Irelands when he got there.
Ireland is about 15, 16?
No, not even. About 6.
About 6 million.
Yeah. 5.
Do you have a counterfeit problem in Ireland?
Do I what?
Do you have a counterfeit problem in Ireland?
I don't think it's very, very evident. I think, as you say, Africa ends up being the dumping ground of some of these fakes and such. But what I'd like to finish just saying, while we have a problem of goods that are fake and people who are trying to, go around the checks and balances and make fake goods, some of the problem we've had, as I said, is people who are fake in their attitude, in their just willingness to believe any rumor or conspiracy theory and all that sort of stuff. So if we sorted ourselves out as Ugandans, I say the potential is there, and the millennials, I see, they're the future. So it'll be very sad if we see millennials just adopt some of the practices from older generations. So come back to your first question: is it the parents or is it the children are at fault? It's both. We need to be giving right role models. We need to be mentors.
Dr. Ian, we would like to thank you very much, Dr. Ian Clarke Busuulwa, IHK. He's also into farming. We didn't have sufficient time to talk about that. He's been into politics. The Ugandans who are watching, the Africans who are watching, where do you buy your products? I believe you consume genuine. Where can they find genuine products? Any clues how to identify the fake? What should they watch out for? Your message, why they should keep away from the fakes.
Stick to the larger known brands and distributors, and don't go to these funny little
shortcuts.
Yeah. When you start to get something for nothing, that's what you'll get. You'll get nothing for nothing.
So those Ugandans bargain a lot, who want cheap upon cheap.
You'll end up with a fake politician, a fake drug, fake everything.
Okay, so that was Dr. Ian Clarke, an owner still of the IHK Hospital, We didn't have a chance to talk about your university. He has IHK.
Clarke International University.
You're offering degrees, masters,
Yes,
diplomas.
in health sciences, in nursing, in IT, and yeah, we do a very good upgrade on an IT, a program called Refactor, which takes IT graduates and then fine tunes them or beats them into shape to do programming and coding and stuff, which of course is it's marketable these days.
Okay, I think we have to stop here. I've not had a chance, as I've said, to talk to Dr. Ian about many things, but I think the next time we have a chance to have him, we shall be asking him about the fake graduates that we have on the market. Are they coming from the Clarke University or coming from somewhere else? But I believe Dr. Ian has made a contribution, a great contribution in helping you appreciate and understand that this is a problem common to all of us. This is a problem that we must fight together. It's not an ASEAN problem. It's not Dr. Ian Clarke's problem. It's not the government's problem. It's not a mother's problem. It's the whole family's problem. So until then, we'd like to thank you for listening, viewing us. Bye-bye.